Thanks for inviting me here today, especially Dale, for contacting our North of Ireland Cancer Research Consumer Forum. And I'm pleased to be able to give this short presentation to you all today. I'm afraid I cannot sing, but I hope you find what I have to say of some use, if not terribly entertaining at times. My own personal background, I'm a biostatistician from 1972. I worked at the University of Ulster, the Queen's University of Belfast, and also at one point was chief biometrician for the Department of Agriculture in the North of Ireland. I've also pursued a separate career as a novelist, which I'll not go into today, but both of these professions actually did prove useful in what is about to come. PPI then in Northern Ireland, the background here is this. The Department of Health in Northern Ireland, after extensive lobbying, endorsed PPI as best practice around about 2010. This was then formally implemented by the NI Cancer Trials Centre network. Right. The Northern Ireland Cancer Research Consumer Forum was then established in 2011, chaired by Margaret Gray, a patient herself, who had extensive experience as a radiotherapist, but had unfortunately had breast cancer, and in recovery got involved with this NICRF group. There is an executive, Ruth Boyd, who is partially funded by Cancer Research UK and the Department of Health, the Health Trust in the North of Ireland. So Ruth is paid, Margaret isn't. Membership is patients and carers, patients like myself affected by cancer who have suffered it, or people who are caring for them. They're all enthusiastic advocates of research and keen to build partnerships with researchers from any background whatsoever. Ruth Boyd, the executive, is based in the Cancer Centre attached to Queen's University Belfast, but we encourage collaboration with research from any organisation whatsoever. All the work is done by myself and other patients and carers on an entirely voluntary basis. The aims is to provide a visible focus and support for PPI. And it's accessible, as I said, for any research with positive potential for people who are affected by cancer. The objectives is to facilitate this across all stages of the research cycle, from prevention, diagnosis, screening, treatment. In the last year or so, we have seen a lot more trials coming through on palliative care. Traditionally, the work had involved more traditional clinical trials. Okay, that's the background to the group. I'm here to talk briefly as a patient myself. In 2011, I was experiencing major blood issue from the anal passage on a very regular and consistent basis, which unfortunately I ignored for too long before going to see the general practitioner. Given my age at the time and the symptoms, the GP referred me to the Mater Hospital in Belfast. Mr. Harvey was the consultant in those days, now retired, and he did a thorough investigation, and any of you who have suffered from this will know what that involves. It's a very intensive probe up your anal passage, which is not the most comfortable experience in the world, and he diagnosed a grade 3 cancer tumour. So he asked me what I did for a living. I said I was a statistician. Oh, he says, well, my brother-in-law is a statistician, and he's quite bonkers. They spend all day doing mathematics. I says, quite a few of them do actually, but I hope you don't put me in that category. I says, how long have I got? He says, how long have I got? The when? He said, I says, Christmas. This was September of 2011, so how long have you got? Big question everyone asks. So he says your chances of surviving 50-50. You're a statistician, you know what that means. So he says, unfortunately, I do. Toss up a coin, I may be here at Christmas and I may not be. He immediately referred me for major surgery and all the tests that involves beforehand, colonoscopies and so on, various types of scan to diagnose what particular state the tumour was in. Anyone here has ever had a colonoscopy, by the way? Well, if you've taken the preparation beforehand, you'll know what that's like. And I would heartily recommend it to anyone who wants to lose weight. I had one recently as a checkup, and well, with the usual results. Sorry about that. Anyway, I'm still above ground. I went into major surgery, which was quite rough, preceded by a major course of radiotherapy, which still has given me side effects. That's why I still hold this. My wife says, would you stop holding your bloody back? But the surgery was actually quite successful. There were a lot of complications. I had to wear a colostomy bag for 14 months. So everything's processed through the bag here, which is not pleasant either. But the prognosis was good. The T cells were holding up quite well. And despite the fact that it was a grade 3 tumour, I seemed to be coping quite well. So I went through a series of tests again over the coming year, and then the consultant recommended a reversal of the colostomy bag. And that had its problems as well, and occasionally still does, but it has been quite effective, and I'm, fairly well back to, not quite back to normal, but doing quite well. Even glad to be anywhere today, as Keith Richards used to say. The feeling then was that I really wanted to give something back to cancer research. I read an article in a newspaper, a local newspaper, telling me about some research that was going on at Queen's University. It was called the Mercuric study, which was trying to assist people with grade 4 tumours which were spreading and were resistant to chemotherapy. And this work seemed to me quite groundbreaking, fascinating to someone with my background, because that is something I might have had to face at one stage. And I contacted the researcher, and they told me about the NICRF. And I contacted Ruth Boyd and Mrs. Grayson, and they took me on as a member of the group. The initial role, without getting into too much detail, involved looking at patient documents which were going to be sent to patients by researchers to assess how meaningful they were. They were largely clinical and epidemiological trials, both prospective and retrospective. And certainly these reviews have come on quite a bit in the last few years. The main problem with these documents that are going out to patients is they're laden with all sorts of jargon, scientific jargon, and have no meaning to a patient whatsoever, unfortunately. The reviews are now embedded with us, all the patient review documents. The thing that the document the patient is actually going to see will be reviewed by one of our group. And we will give honest assessments of how meaningful this would be to a patient. That's where the novelist bit come in, because plain English or plain Irish is what is needed. And I spent the first few months really getting documents from all sorts of areas, and my background as a statistician also helped, because there's no point starting to talk to patients about power calculations and all the rest of it. My particular interest in recent years has, of course, been in bowel cancer. There's a major project at the moment, the ESCORT project, stratification, personalization processes for colorectal cancer. The lead is actually from the ROI. Professor Lawler from UCD is the lead on this particular work. He's Dean of Medical Education at Queen's University. And they have attracted, with Oxford, major ECU funding, around about £5 million over 5 years, to look at all the areas of research which can assist in personalised medicine for colorectal patients. There's such areas as new biomarkers. Can we eradicate even the need in the future for radiotherapy and in many cases chemotherapy? And there are a lot of other strands to this research, and this is ongoing at the moment, and one which is pretty fascinating for a patient. There is, I think, a major publication on this coming out next week, I'm told. So if you keep an eye on cancer communications, if you're interested, you might find that very useful. But the group is not supposed just to concentrate on their own particular problem, concentrate and help on other trials as well. And again, the statistical experience has come in useful. There's a major trial called the BALAD trial. I can't even remember what the acronym means there, but it's dealing with adenocarcinoma, where the carcinoma cannot be diagnosed from the back end or down here as well. It's very difficult. It presents very late in the day and is lethal in many cases. There's a big trial going on there looking at new combination drug therapies following surgery to see what impact that has on survival. And there's quite a lot of interest in this actually since Christmas from France and Japan, and America has been approached. I haven't heard anything from them yet. It's not just the traditional trials. There's a major trial called the Easy Switch trial funded by Cancer Research UK, which is looking at the control of sepsis. The problem here being, as I understand it, that someone may be treated with chemotherapy, they may be treating at home, and sepsis occurs, and it's automatic now. You're brought into hospital and kept there for 3 weeks. There's new therapies available where maybe people could be brought in, the sepsis rapidly brought into control, and oral therapy conducted at home. So someone who had spent a major period of time in hospital, I can relate to this totally. Anyone who's spent, some of you have a month in hospital environment, great as the staff are, it's not the most pleasant experience. There's a major study which is actually near analysis at the moment called the Habitura study, which is looking at biomarkers for bladder cancer. The surgeon explains it to me. Many people present with blood and urine, but it might be a result of something, minor accident or something like that there. And how do you differentiate that in a more simple way from bladder cancer, the more sinister bladder cancer? This is funded by a local laboratory, Randax Laboratories largely. You may have heard of, if you're a horse racing fan, they have recently supported the Grand National of the Entry. They must be making plenty of money somewhere along the line, but they've given some of it to this trial. We've actually 660 patient samples at the moment, and they're under analysis, so we will look forward to some publications on that in the coming months. But we, as I say, we get hit with a number of research projects from all areas. Prostate, new radiotherapy developments are fascinating. One thing I should have mentioned earlier, during the course of my own treatment, my younger sister died of pancreatic cancer, one of the more sinister cancers, and with, again, late presenting signs. She had pain in her tummy and referred to the Antrim Area Hospital and died within 3 months. Never got out again. So an extra impetus for me to try and keep involved in collaboration with researchers. And we are also involved with new generic, you're probably more aware of these new genetic approaches to treatment of breast and ovarian cancer. Looks like I'm spot on time here. So just to summarize, while the NICRF started fairly slowly, in the last 3 years or so, nothing to do with me, the last 3 years or so, there has been a steady growth in their work and involvement with major research. Some younger researchers think, oh my God, another bureaucratic exercise. That is not the point. The point is to help people, to help patients. That is the ultimate point, of course, but we are there to help researchers. Clinical trial recruitment is still pretty low. It's like 18%, something like that in the north anyway. And we have found with many projects, with our input, the grants come in, the work gets rolling. I was involved with ethics committees in the past, and there's no patients on them, and they're telling you what a patient might think of this. Better if the patient tells you in the first place, and then the message would get to some of these people that, the patient voice has been heard, and they've had a view, and the earlier speakers have, I'm sure you all agree, how important this is. The ultimate thing is, of course, enhanced patient experience and care. So the bell is gone. To hear a lot about Brexit this day, but I'm afraid my soundbite is that tumours know nothing about any borders. There's no point talking about Brexit or Mrs. May or Mrs. Foster. They know no borders whatsoever. They're dangerous beasts, and we've got to beat them. Thank you.